Good afternoon and welcome to March Grand Rounds for St. Luke's University Health Network Physical Therapy and Rehabilitation. This month we have Dr. Georgia March with us talking about high-intensity exercise for high-intensity boxing for Parkinson's disease. Dr. March received her Doctor of Physical Therapy degree from Quinnipiac University. She's board certified in neurologic physical therapy and holds advanced certifications for specific treatment of Parkinson's disease, including LSVT Big and Rocksteady boxing. She has worked in a variety of settings, including subacute rehabilitation, acute rehabilitation, and currently in an outpatient neurologic setting. She has special interests in the treatment of amputees, pre- and post-prosthetic training, vestibular disorders, and neurologic disorders, including Parkinson's disease. And she's been a clinical instructor to many students and plays an active role in mentorship of new employees. I just want to remind everybody, make sure that you are muted. Unless you have a question, then please unmute and ask. Also, in the invitation that you received on Outlook, there is a link. Please click that link or go to that website or scan that QR code, because that will help you log in to get credit, CE and CME credit for this event. If you are watching this online, that means you've already clicked on the link to get yourself in there anyway, so you don't have to worry about that. So without further ado, I will turn this over to Dr. March.
Okay, hi everyone. My name is Georgia, and like Steve said, I'm going to be presenting on high-intensity boxing for Parkinson's disease. Okay, so this is just the activity description and statement of need. The target audience today is for all providers. This is our designation statement. Disclosure information. I have no relevant financial relationships to disclose. And these are our learning objectives. So today our three objectives are to identify the 4 cardinal signs of Parkinson's disease, to discuss the benefits of high-intensity exercise for the treatment of Parkinson's, and to describe parameters for implementing high-intensity exercise for patients with Parkinson's. So the first things we're going to go over is just general information about Parkinson's disease and the treatment of it. So the definition of Parkinson's disease is a chronic progressive central nervous system disorder that results from death of dopamine-producing cells in the substantia nigra, which is part of the basal ganglia. So what occurs is there's progressive loss of dopaminergic cells in the substantia nigra and dopamine depletion in the striatum. So that leads to dysfunction in corticostriatal networks that are essential for control of movement and cognition. So those are the 2 main deficits we're going to see. We're going to see movement disorders, and we're also going to see cognitive impairment. Parkinson's is the second most common neurodegenerative condition, with Alzheimer's being the first. And the etiology of Parkinson's, 90% of cases are sporadic and 10% of cases are genetic. So there are different types of Parkinson's disease. The most common is primary Parkinsonism or idiopathic Parkinson's disease. This makes up 85% of cases. So this is most commonly what we are seeing and treating in the clinic. There's typically a unilateral onset that progresses slowly over time. And for diagnosis of this type of Parkinson's, there needs to be the presence of at least 2 of 4 cardinal signs, which we will talk about in a little bit, and a positive response to levodopa, which is a medication used to treat Parkinson's, and we are also going to get to that in a little bit. There is also secondary Parkinsonism. This is caused by some type of secondary factor, so it can be from vascular causes, it can be drug-induced, it can be from infection or due to toxins. So this type of Parkinson's does not respond to levodopa therapy since it's from a secondary cause rather than the dopamine depletion. But the signs and symptoms would be very similar to the primary Parkinsonism. And then just really quickly, I wanted to mention that there are also Parkinson plus syndromes. So these are atypical types of Parkinson's disease. There are 3 of them. So the first one is progressive supranuclear palsy, or PSP, multiple system atrophy, or MSA, and corticobasal ganglionic degeneration, or CBGD. So these types of Parkinson's, they can still present with some of the typical signs and symptoms, but they also have some other unique symptoms associated with each of them. And the main thing to know about these is that all of them have a poor prognosis with a much shorter life expectancy, and they would not respond to levodopa medication either. So this is the modified Hone and Yahr scale. This is what is used to classify what stage of Parkinson's disease someone is in. So it's a scale from 1 to 5, 1 being very mild involvement and 5 being the most severe. So this is used by neurologists. It can be used by physical therapists. It's basically you're observing their symptoms and how much involvement they have to classify them into these stages. So it's important for us to know what stage someone is in because that will help direct our treatment as far as what type of cueing we should be using for the patient. So if someone is in the early stages of Parkinson's disease, they are still able to use internal cueing. Versus someone who's in the later stages, those are the patients who really need those external cues. So like a metronome or using tape marks on the floor for them to increase their step length, anything like that. So that kind of helps to guide our treatment a little bit. So earlier I mentioned that Parkinson's is diagnosed by the presence of 2 of 4 cardinal signs. So these are those 4 cardinal signs, and you can use the acronym TRAP to help remember them. But the first one is tremor. The next one is rigidity, then akinesia or bradykinesia, which basically means slowness of movement, and then postural instability, which means balance deficits. There are also other motor signs associated with Parkinson's disease. So I think one of the most common ones that we see is freezing of gait. We also can see a forward flexed posture. We can see coordination issues, so both gross and fine coordination. Hypomimia, which means facial masking or the loss of facial expressions, dystonia, which means involuntary muscle contractions, and dysarthria, which is slurred speech, and that's caused by weakness in the muscles that are used for speech. So in addition to the motor signs, there are also a lot of premotor and non-motor signs that we can see. So typically, once the motor signs are present, there already is 60 to 80% loss of dopaminergic neurons. So that's a pretty substantial loss for those symptoms to even emerge. So before that occurs, we can see a lot of non-motor signs that might be mistaken for something else and might not cause anyone to suspect that it's Parkinson's disease. So some of the non-motor signs are loss of sense of smell, sleep disturbances, mood disorders, most commonly depression, dysautonomia in the form of orthostatic hypotension, which we'll talk about in a few slides as well. Constipation, dysphagia, hypophonia, which is decreased voice volume, fatigue and stiffness. You can also see micrographia, so small handwriting, sialuria, which is increased drooling or salivation, and then also cognitive dysfunction can start to present as well. So we're going to talk a little bit about treatment of Parkinson's disease. So first off, we're going to touch on medication. Carbidopa levodopa is the gold standard medication used for symptom management. So I just wanted to point out there are no medications that are proven to slow the progression of Parkinson's disease. So the medications are really meant to treat the symptoms. And having someone on an appropriately optimized levodopa treatment program is important for them to participate in physical therapy and exercise programs. So a little bit more about that medication. Carbidopa levodopa, it's commonly known as Sinemet. Typically, this medication is taken 3 to 4 times throughout the day. Common side effects are nausea, confusion, dyskinesias, which is like involuntary writhing movements, and orthostatic hypotension. And this medication also has on and off times. So what that means is when someone is at the peak dose of the medication, that's when the symptoms are going to be the most lessened, but that's when we could see more of the dyskinesias, more of those unwanted movements. And during the off times of the medication, that's where the patient is going to be more symptomatic. So maybe they're going to have more freezing, be more forward flexed, more tremor, be more rigid. So it's important for us to be aware of the on and off times because that is going to play a role in maybe when we're scheduling their therapy times around the on and off times of their medication. Oh, and the reason that carbidopa and levodopa are combined together into one medication is because the carbidopa prevents the levodopa from being converted into dopamine prematurely. So basically it just allows more of it to get to the brain. So that's why it's combined like that. So I've mentioned orthostatic hypotension a few times. So this is one of the non-motor symptoms of Parkinson's disease. This is also a side effect of the medication. So this is something that's pretty important for us to be aware of. So checking blood pressures in supine, seated, and standing, making sure that the patient is adequately hydrated, and then possibly TED stockings or abdominal binders if that's indicated. So this is just something for us to be aware of when we're working with this population. Okay, so we know now that medication is the gold standard for treatment of symptoms. Exercise is basically the gold standard for slowing disease progression. So there is a lot of evidence out there that is supporting vigorous exercise, slowing the progression of PD. And that is very significant because the medication doesn't do that. Like the exercise, that's really the one thing we know that can slow disease progression. So that's huge. I don't know what happened. Hold on one second. So there's a lot of research studies on exercise. We know that it's important for people who have Parkinson's disease, but where do we start? There's a lot out there, so it can be a little bit tricky to kind of sort through it all. So this is a list of evidence-based interventions. So there are RCTs, a lot of research studies out there supporting these types of interventions. So first off, high-intensity exercise. There's also a lot of evidence for forced-use cycling, aerobic exercise, treadmill training, boxing, which we're going to get into later, dancing, Tai Chi, yoga, dual task training, and LSVT Big, which is a specific program designed for people who have Parkinson's disease. And we're going to talk about that a little bit later as well. So I just wanted to include this list because it just shows that there's a lot of different options out there. Like if someone's not interested in boxing, maybe they're more interested in dancing or yoga, like we can really tailor our exercise plan to each patient and kind of like what their interests are. Okay, so the research on high intensity exercise, the initial rationale for the evidence of exercise slowing PD came from animal studies. So basically, animal models of Parkinson's disease showed that physical exercise improved dopaminergic function in the striatum. So they used long-term running exercise, and that showed improved cognitive outcomes, increased brain neurotropic factor concentrations, enhanced biomarkers, and microscopic evidence of neuroplasticity, and it attenuated neurotoxin-induced Parkinsonism. So we got a lot of information from the animal studies, then able to kind of translate that over to human studies. So in healthy individuals, exercise increases serum BDNF concentrations. It also reduces risk of dementia or cognitive decline. In individuals who are already cognitively impaired, exercise can improve cognition as well. And then in individuals with Parkinson's disease, we also see increased BDNF levels after exercise, reduced cognitive decline, and improved functional MRI brain activation and connectivity. So BDNF that stands for brain-derived neurotropic factor, and that's a key molecule involved in plastic changes related to learning and memory in the brain. So use of functional MRI showed increased brain activity in these areas of the brain. And these areas play a role in motor function, but also non-motor function, such as executive function, planning, attention. So these areas showed increased activity during their resting state. So that shows us that not just during exercise, we're having improvements in these areas, but even afterwards, during rest state. So we're having like carryover as well. Okay, in early Parkinson's disease, the posterior putamen is a part of the brain that's more heavily affected by dopamine depletion. So that meaning the anterior putamen is relatively spared. So basically, there was a study that showed after 3 months of aerobic exercise, there was increased dopamine release in the anterior striatum, showing that exercise may actually strengthen anterior striatal function. So that just tells us that that allows patients with Parkinson's disease to basically compensate and utilize the anterior putamen rather than the posterior. So that's just telling us that exercise is allowing them to actually utilize different areas of the brain that are less affected. Okay, the next slide, we're just talking about an RCT. It's called a high intensity exercise boot camp for persons with Parkinson's disease. This is a randomized controlled trial. And basically the findings from this study showed us that there were no adverse effects compared to the usual care low intensity exercise group. So high intensity exercise can be safe to perform. The high intensity group did improve in more functional outcome measures. However, the BDNF, it did improve for both groups. So that's telling us that exercise is beneficial in general, but that high intensity group did have more functional improvement. So we know that high intensity exercise is beneficial. We know that it can reduce cognitive decline. It can increase BDNF in the brain. It can increase different resting state areas of the brain function. So how do we implement that? There really are not a lot of investigations that provide insight into the ideal exercise duration. So I kind of started here with the American Heart Association guidelines. So they recommend moderate intensity aerobic physical activity for a minimum of 30 minutes, 5 days a week, or high intensity aerobic exercise for at least 20 minutes, 3 days a week, and then also resistance exercises twice a week. So most of the studies that I looked at, they had their exercise programs performed at least 3 days a week over a period of a few months. Most of the exercise sessions were about 45 to 60 minutes long. So that's kind of in line with what we see as physical therapists. Like we're typically seeing our patients 45 to 60 minutes 2 or 3 times a week. So the next thing we want to discuss is what is considered high intensity exercise? Like how are we measuring that and how are we making sure that we are working someone at a high intensity? So according to the American College of Sports Medicine, there are 4 methods that we can use to assess high intensity. So we're going to go into a little more detail about each of these. So there's the talk test, heart rate monitoring, rating of perceived exertion, and then motion sensors. So I think when most people think of high intensity, they might be just thinking of like heart rate monitoring, but there are other methods that we should be using as well. So the first one is the talk test. This is relatively easy to implement. If someone's working at a vigorous or a high intensity, they should be unable to sustain a full conversation. They should really only be able to just utter a few words to you at a time. And that's kind of a quick, easy way to gauge if they're working at a high enough intensity. If they're able to sustain a full conversation pretty easily, then they're likely working at more of a moderate intensity. The next thing we can do to monitor is, next thing we can check is heart rate. So I think this is what most people think of. So we can check heart rate manually. We can use like a pulse ox. I think the best method is using heart rate monitor, like a wristband. And a lot of people have like Fitbits or Apple Watches, and that monitors heart rate as well. So this is also pretty easy to implement. So if someone's working at a high intensity, we are looking for them to be at 76 to 96% of their heart rate max. A moderate intensity would be more 65 to 75%. So the way that we can calculate what someone's heart rate max is, one of the most common formulas is using 220 minus their age, and then you would multiply that by 0.76 and then by 0.96, and that would give you your range. There's another formula as well that's a little bit more specific. It's 208 minus 0.7 times age, and then you would also multiply by the percentages that you want to get them in. I just lost my train of thought, sorry. A lot of the research studies that I looked at, they did use the 220 minus age, so I did include both of them in here. Wanted to just mention that if someone is on beta blockers, which is a cardiac medication, typically ending in OLOL, or if someone has a pacemaker, we really cannot be relying on heart rate. So it's important to utilize these other methods that we're going to talk about. Okay, next, we're going to go with rating of perceived exertion. So there are different scales, and in my next slides, I'm going to show you what those look like. But this is basically just a visual scale. It's a subjective rating. You would show the patient the scale and ask them where they would rate the activity on that scale of either 1 to 10. And then there's also the Borg RPE scale, which is a scale from 6 to 20. So if someone's working at a high intensity, they're going to be closer to like that 7 range if we're going off the 1 to 10 scale. And moderate intensity, they would be around a 3 to 4. So this is what a 1 through 10 scale looks like. And there's descriptions next to each one. So basically, for high intensity, we're looking for like more of that 7 range. So vigorous activity, borderline uncomfortable, short of breath, but can speak a sentence. So that kind of lines up with that talk test. Like they can kind of say a couple words, but not really sustain a full conversation. This is also a 0 to 10 scale. So about the same as the other one. And then I think commonly we use the Borg 6 through 20 scale. So if someone is working at a high intensity, we would want them to really be rating the exercise around like a 15 to a 17. So it should feel hard. If they're more around that 11 to 13 range, that's more of a moderate intensity. So you can choose whichever one you want to use. Just stick with the same one for consistency. You could print this out, hang it up around the clinic, and basically be checking in with your patient after each exercise and having them rate that. And then we can include that in our documentation as well. Okay, and then the last one is using motion sensors, so like step counters. So if someone's working at a high intensity, they would be taking greater than 100 steps per minute. Moderate intensity would be less than that. So a common recommendation is achieving 3,000 steps in 30 minutes. And then high dosage training. So for example, high intensity gait training for stroke would be, the recommendation would be 2,000 to 6,000 steps per day. So this is another method of us to assess if someone is working at a high enough intensity. Okay, so now to get a little bit more into specifics about St. Luke's, physical therapy at St. Luke's has 4 specific neurocenters. So what that means, what classifies as a neurocenter is basically having a multidisciplinary approach. So having physical therapy, occupational therapy, and speech therapy. So we have highly specialized therapists with extensive knowledge of PD. We also have a Parkinson's disease support group called PD Steps. So that's meets once a month virtually. That's not specific to physical therapy at St. Luke's. That is for the entire network. These are our 4 locations. So I work at the Phillipsburg Hillcrest location. We also have 8th Avenue in Bethlehem. We have our Lehighton location, and then also in Emmaus. So all 4 of these sites are neurocenters, meaning they have PT, OT, and speech. I did want to mention there are other PT locations within the St. Luke's network that have neurotherapists, such as Wingap, Clinton, Quakertown. So they have PTs there who specialize in neuro as well. They just don't have all 3 disciplines, so they wouldn't be considered the an official neurocenter. Okay, so what physical therapy at St. Luke's has is specific programs to treat Parkinson's disease. So there are 3 specific programs. There's LSVT, Big, and Loud. So Big is the PT part and Loud is the speech therapy part. There's also POWER, which stands for Parkinson's Wellness Recovery. There's also Rocksteady boxing. So clinicians need to be certified in these programs in order to provide them to patients. You can be certified as a PT or an OT. And for speech therapists, they can be certified in LSVT Loud. So at the Hillcrest location, we do have clinicians who are certified in all 3 of these programs. Myself personally, I'm certified in LSVT Big and Rocksteady boxing. Okay, so what are our goals of physical therapy working with this population? So our number 1 goal is slowing the progression of disease, and we know that exercise has been proven to do that. Our other goals, we want to prevent and reduce falls, improving balance, increasing strength and flexibility, and then improving ability to perform functional activities, return to sport or to leisure activities, and basically get these patients back to doing what they want, what they want to be doing. So just kind of going through what a PT evaluation for Parkinson's disease would look like. So for our subjective, we're going to ask like onset of diagnosis and the symptoms. So how long have they been diagnosed with Parkinson's disease? Is it newer, or have they been diagnosed for the past 20 years? We want to know what their fall history is. How many falls have they had in the last year, in the last 6 months? We want to know what type of assistive device they're using. Have they been using it for a long time? Have they recently had to switch to something different. It's like if they were using a walker and maybe more recently they've noticed a decline and now they're using a wheelchair. So we want to know that information. We also want to know social support. Do they live by themselves? Home setup. So do they have stairs at home? That's important for us to know. And then we want to ask them about their medication dosing. So we want to know how many times a day are you taking your medication? What time of day are you taking it? That way we can possibly time therapy sessions more around like the on times of their medication. Our objective information, we are going to be looking at strength, so using MMT. We're looking at tone, since rigidity is one of those cardinal signs and symptoms. We want to know, are they having more rigidity on one side of the body? Is it more bilateral? So that's going to also allow us to start to get an idea of what hone and yar stage they're in, if they're in one of the earlier stages or if they're in one of the later stages, because then we're going to have more information about how we should be cueing this patient during their therapy sessions. We want to look at range of motion, coordination, balance, and then there's specific outcome measures that we want to be using for this population. So that's what we're going to talk about next. So I know this slide has a lot of words on it. This is basically information from the PD Edge. So PD Edge, there was a task force from 2014, and they basically developed these outcome measures as the gold standard, highly recommended measures to be using for Parkinson's disease. So it's split up into 3 categories. So we have body structure and function, activity limitation, participation restrictions. So the one I wanted to talk about in particular is the MDS-UPDRS. So that's kind of listed under both body structure and function and activity. So this is the most widely used clinical rating scale for Parkinson's disease. A higher score on that indicates greater impact of PD symptoms. So this can be performed by a neurologist, by a PT or an OT. So there's different sections. It's a pretty lengthy outcome measure. So it's not something that we would necessarily be performing the entire thing at once, because there's different sections. The one that's more relevant for us as PTs would be gait, functional mobility. OT might be looking more at the upper extremity section. There's a cognitive section. Speech therapists might be looking more at the swallowing section. There's also sleep, quality of life. So it's pretty extensive. It's looking at a lot of different areas. And this outcome measure was used in a lot of the research studies that I looked at. So using that score as a way to track improvement. What else? 6-minute walk test, 10-meter walk test. So we're looking at gait endurance, gait speed. The mini best is looking at balance. FGA looking at balance and fall risk. 5-time sit to stand also looks at fall risk. And the 9-hole peg test is looking at upper extremity function. They also include the Montreal Cognitive Assessment, or the MoCA, as one of the highly recommended measures, and that's assessing cognitive function. And then under participation, there's the PDQ-8 or PDQ-39. So that stands for Parkinson's Disease Questionnaire. The PDQ-8 is basically a shorter version of the PDQ-39, but that's a survey that you can give your patient, and that's assessing more quality of life. Okay, so for treatment of Parkinson's disease, there are specific principles that we want to be focusing on. So the first one being large amplitude movement. So Parkinson's leads to dopamine depletion in the brain. This is going to lead to overall smaller amplitude movements. So everything that we're doing, we should really be emphasizing big movements. And we're going to talk a little bit more about that on the next slide with LSVT Big program. Other things we want to focus on are things that are going to incorporate trunk rotation. This is going to help to break up a lot of that rigidity that we can see. Also increasing step length, so trying to address that very typical shuffling gait that we see in people with Parkinson's disease. And then also specific exercises to reduce freezing episodes. Okay, so I wanted to just kind of talk briefly about LSVT Big. For those of you who are not familiar with this program, it stands for Lee Silverman Voice Treatment. So this program was actually started in 1987, and it was initially founded more as the LSVT loud component. So it was initially created to address the quieter voice quality associated with Parkinson's disease. The Big part was founded in 2002, kind of based on the same principles. So this was initially created as a speech treatment, and then it progressed to the Big component, which is the physical therapy or occupational therapy treatment of it. This is considered an intense program. It is a very structured program. It's the same 8 exercises performed in the same order. You are supposed to perform this every single day. So it's recommended that the patient comes in for physical therapy 4 days a week, and they're to be performing the exercises twice a day, every day. So the days that they're coming into the clinic with us, they're performing it once. They're supposed to go home, perform it again later. On the days that they are not coming in, they're supposed to be doing it at home twice a week. So it's very rigid, very structured. There are 2 seated exercises and 6 standing exercises. There are a lot of modifications. So if you do have a lower level patient, you can modify it to all seated. You can even modify it to supine if necessary. Because it's so rigid and structured, this is really good for patients who are experiencing memory or cognitive issues because it's a lot of repetition. It's the same thing. It's the same exercises over and over. And again, for this program, you need to be a certified LSVT clinician. So you can be either a PT or an OT and be certified to do this. So next, I just wanted to include a video. It's just like a quick, like 1.5 minute clip, just so you can kind of get an idea of like what the exercises look like.
I'm gonna have to talk over it here.
Okay, that's fine.
Two types of protein that make your arthritis pain worse.
Let's start with your big posture.
So
Watch Jenny
talk
and
over
do
it.
what she does.
Okay, so this is just a quick clip. You can find this on YouTube if you type in LSVT. The cueing, so you guys can't hear the video, but the cueing that she's giving is reach big, reach down to the floor, and then reach big. So basically what they're saying in this video, they're saying the word big a lot, like reach big, stand big.
You're going to start with your feet apart.
So starting with feet apart in a big posture. So really everything that they're saying is emphasizing those big movements, so large amplitude movements. So she's saying twist big with big movement and come back nice and big. So it's a lot of that cueing.
Twist palms up, nice and big, and back big. Reach big.
So for sit to stand, she's saying reach big, up big, reach back big, and down. So a lot of that cueing, and then the last part is walking big.
To use that same effort when you walk and when you participate in your normal daily activities. Wherever your feet take you, we want you to walk with bigger steps and bigger arm swings.
So walking with big steps, walking with really big arm swing, trying to normalize more of a normal walking pattern.
Welcome and thank you for joining for today's webinar. The title of
So this program is already kind of considered a little bit, it's considered an intense program just because of the frequency that the exercises are being performed. It's daily, it's twice a day for a lot of patients with Parkinson's disease. Like that in itself is pretty intense. They're also they're supposed to be rating each of the exercises pretty much using like a 0 to 10 Borg scale, and they're supposed to be working at like a 7 intensity or higher. So again, from what we talked about in the previous slides, like that, we know that a 7 out of 10, like that's considered a high intensity. So there's other ways that we can make this high intensity. So if someone's been performing this program for a few weeks and they're starting to, they've got the hang of it, they're starting to rate it as feeling, not so hard anymore, we can add ankle and wrist weights. We can use a weighted vest. We can use other pieces of equipment to challenge them more. So hurdles or foam pads. The seated exercises can be performed on a physio ball or a Dynadisc to make it more unstable for them. And then same thing, we can be monitoring, having them rate everything on the RPE. We could be monitoring their heart rate as long as they're not on beta blockers, and then using the talk test as well. Okay, another program that is POWER, so Parkinson Wellness Recovery. This is a little bit different from LSVT. This is still a Parkinson disease specific neuroplasticity principled exercise program. So again, you must be certified as a POWER coach. This program was founded in 2010, so pretty recent. This program really emphasizes exercises being performed in different neurodevelopmental positions. So there are 4 exercises in each of these positions. So there's 4 supine exercises, 4 prone, 4 quadruped, 4 kneeling, and 4 standing exercises. So you basically perform each of those exercises in what's called a flow. So you would perform one exercise like right after the other. This is a little bit more challenging for someone who has cognitive impairments. It is not as structured as LSVT Big and Loud. There's a lot of variety, a lot of variation in it, but something specific to this program is that it teaches patients how to do floor transfers. So part of those quadruped exercises involve the patient learning how to get from quadruped into kneeling and then back up to standing. So that can be useful to use as well. So different ways we can make this high intensity, kind of the same as LSVT Big and Loud. We can add ankle or wrist weights, weighted vest. We can be combining the movements into more of like a flow or almost implement it more as circuit training. That way we're making it more challenging for them. And then same thing, we can have them wearing a heart rate monitor, have them rating each exercise with the RPE or utilizing the talk test, seeing if they can carry a conversation with you as they're doing it. So this one is meant to be more dynamic versus LSVT that's more structured. And what we're going to talk about next is Rocksteady boxing. So this is also a little bit more dynamic, not as structured as the LSVT Big and Loud. So the first thing I have on here is the mission statement from the website. So it's a nonprofit organization. It gives people with Parkinson's disease hope by improving their quality of life through a non-contact boxing-based fitness curriculum. So this was founded in 2006, so also relatively newer. All of these Parkinson's disease programs have been founded like within the last 20 years or so. This is something that's been gaining a lot of popularity recently. This is a way that we can implement high intensity exercise for our patients in kind of a fun and a different way. We're going to talk a little bit more about research later on. So far there have really just been mostly case studies done on boxing for Parkinson's and on Rocksteady boxing specifically. I think there's like 1 or 2 RCTs. There's really not enough high quality evidence yet, though I'm sure more is coming out. And then the reasons why boxing has even been found to be beneficial for patients with PD, like why even decide to try this with patients, it really does emphasize a lot of those principles that we talked about earlier. So it emphasizes large amplitude movements with the punches. So a lot of those big movements. It also emphasizes trunk rotation. So a lot of the punches do involve the patient needing to rotate their trunk. The footwork associated with boxing and like the agility work is really helpful with reducing freezing episodes and increasing step length. So it really kind of touches upon all of those principles that we spoke about earlier. Okay, so the physical therapy at St. Luke's Hillcrest location is an affiliate site for Rocksteady boxing. So what that means is we went to a training course, we became certified Rocksteady boxing coaches, and we pay an annual fee to be an affiliate site. So we can advertise and promote ourselves as Rocksteady Boxing because we are an affiliate site. And on the next slide, you'll see our logo. If you search us on the Rocksteady Boxing website, you'll find us. PTs and OTs can become Rocksteady Boxing coaches, as well as PTAs, CODAs, and personal trainers. So a couple of us had got initially certified. Any other clinicians who work at this site who are interested in becoming Rocksteady boxing coaches can become certified via the online course. I also included a picture of the St. Luke's Fitness Center that is located in the same plaza as us. So we can also utilize that space as well if we have larger class sizes or if we want to use any of the equipment over there as well. This is our logo for Rocksteady Boxing St. Luke's. Again, you can, if you go on the Rocksteady website and you kind of type in the Phillipsburg or the zip code, will come up on there. Okay, so for Rocksteady boxing, I mentioned that it's not as structured or as rigid as LSVT, which is true, but there is kind of just like a general class format that we do follow. So there's always a warm up, then there is shadow boxing, which I'll explain later. Then we go into boxing combos and circuit training. Then there is always a core section and then followed by a cool down or a stretch. So the typical classes are actually designed to be 90 minutes long, which is pretty long, but that allows us to spend more time. Like you can kind of do a longer warm up or in a longer cool down. It allows you to kind of spend more time in each of these sections. We can modify this though to 45 or 60 minutes. And when we do that, we can tell the patient to perform the warm up independently. So make sure that they're doing the warm up on their own before they're coming into the clinic. And then same thing, make sure they're doing the cool down on their own when they leave. So doing their stretches kind of independently. And that'll allow us to have more time to really focus on the shadow boxing, the circuit training, and the core exercises. Okay, so what I wanted to just talk about next is kind of like a boxing program example for different, and kind of comparing it for different patients. So comparing how we would modify things for like a lower level patient and a higher level patient, because I think a common misconception is that if someone is in the later stages of Parkinson's disease, so like a Hoehn-Yahr stage 4 or 5, where they're maybe using a walker or even a wheelchair, people might think that they're not appropriate to participate in this type of a program, and that's not the case. We can really modify anything to individualize and tailor each program for each patient. So for the warm up, for a lower level patient, maybe we're focusing on more seated type of warm up exercises. So like in the LSVT Big video that was on before, like that seated floor to ceiling type of a stretch, that's a great warm up. Maybe we're focusing on more functional stuff. So like sit to stands or even just walking laps around the clinic or using the new step. For a higher level patient, we can kind of focus on more dynamic type of stuff. We can get them on the treadmill, have them doing a lot more balance and agility type of walking exercises as a warm up. So sidestepping, forward, backwards walking, things like that. Okay, next is going to the shadow boxing. So shadow boxing is basically just practicing 20 repetitions of each punch. So there are 6 punches. And this is not specific to Rocksteady. This is kind of just like boxing in general. There are 6 punches. They are called out by their numbers, so 1 through 6. So 1 is a jab, 2 is a cross, 3 is a dominant hook, 4 is non-dominant hook. Then there would be 5 and 6 would be uppercuts, so non-dominant and dominant. So we're also focusing on stance when we're doing shadow boxing. So that's an important part of boxing, and it's important for our patients with Parkinson's disease too. So the proper stance for this is putting your dominant foot staggered behind. So if you're right-handed, you would basically like step your right foot back. Your feet should not be really narrow. They should be more like railroad tracks, like they each, it's not like tandem. It's really, you're having a wider base of support, just one foot staggered in front of the other. And then you're doing 20 repetitions of each of these punches. So again, you're calling them out by the number. So this is also adding kind of a cognitive component as well, because the patients who are participating in Rocksteady or boxing program in general, they need to be able to remember like which punch is which number. And then once we get into more complex combinations, they're needing to recall that. So we might give them combos that are like 6 numbers in a row. So they're needing to be able to recall like which number is which punch. So even though the stance is an important aspect of this, if we have a lower level patient, we can absolutely modify this and just do it seated. So they're not going to necessarily get the footwork part of it, but they're going to still get the benefits of doing the large amplitude punches. For the higher level patient, then we're definitely doing this in standing and we're focusing on that proper stance. And the shadow boxing is almost really like a form of like neural priming. Like we're performing 20 repetitions of each punch, like we're priming them, we're getting their brain ready to go into the circuit training and the more complex combinations. Okay, so circuit training, this can be, so I wanted to include some examples, but this can be so variable. Like we can really modify this to the patient. We change it up every time. It's never like the same circuits. It's never the same exercises. Like we're always trying to do different things and modifying it for each patient. So Typically, we're doing the circuits like 2 to 3 minutes each. We can do it for about 2 or 3 rounds. So we're focusing on combinations. So that's like any combination of those 6 punches that we just talked about. So if you're working with a lower level patient, we're going to want to keep those combos more simple. Maybe we're just giving them like 2 at a time, like we're giving them like 1, 2. For a more higher level patient, and if we're wanting to incorporate more of a cognitive challenge for them as well, we'll be calling out like 6 or 7 numbers in a row, and they're having to just perform those punches from memory. For the lower level patients, maybe we're focusing more on just like transfers, functional mobility, upper body strengthening. For either patient, we can use the punching bag for punching drills, the speed bag, and we can also include fine motor components like fine motor stations or cognitive stations as well. Something else we can use at the Hillcrest Clinic, we do have a solo step, which is basically a harness system. It's connected to a track on the ceiling. It's not a body weight support system. It's just a fall prevention system. So if we have a lower level patient, but we want them to try to do some of these punches in standing, or if we want them to try to work on some agility and footwork, maybe using the agility ladder, we can absolutely put them in the solo step for safety and then be able to challenge them in that way as well. Okay, then we always have a core section towards the end of the session. So for a lower level patient, maybe we're going to focus more on supine or seated core exercises. And for a higher level patient, maybe we're doing more dynamic stuff. Maybe we're doing like quadruped stuff, getting them on the floor, planks if we have them over at the gym, battle ropes. So again, like these are just examples, but you can really tailor this and make it however you want it to be. And then at the end, we're going to end with cool down and stretching. So same thing. There's not really any like specific stretches you need to perform every time. It's really based on your patient. If someone maybe is having more tightness in their hamstrings, you can incorporate that. If depending like what you kind of focused on in that session, maybe you want to do more upper body stretches. So again, for a lower level patient, we can have them mostly seated for the stretches. For a higher level patient, they can be standing, they can be maybe down on the floor, you know, whatever you think is appropriate. Okay, so I wanted to include a patient example, someone that we have seen at our clinic. He's a 73-year-old male with the MSA type of Parkinson's disease. So that's actually one of those Parkinson plus syndromes, stands for multiple system atrophy. So one of his main symptoms, in addition to kind of the typical Parkinson's presentation of kyphotic posture, shuffling gait, reduced trunk rotation, one of his main symptoms was orthostatic hypotension, which we know is one of the non-motor signs of Parkinson's. It's also a side effect of levodopa, and it's also, that's a specific symptom to this MSA type of Parkinson's. So when he came to us, his primary mode of mobility was a wheelchair. So he was absolutely in like the stage 5 Hoehn-Yahr. So really more severe disease progression at that point. He was walking only short distances with his rollator, with his wife. I believe she was using a gait belt to guard him as well. And he had multiple falls over the past year. But when he came to our clinic, he had expressed an interest in participating in the Rocksteady boxing program. So we basically started him primarily with a seated boxing program, able to progress to some standing boxing as well. So after a few months of working him at a high intensity, he was able to fully transition to the rollator. So he no longer needed to use the wheelchair. He was able to walk much further distances with the rollator. That became his primary mode of mobility. And also we noticed that his blood pressure actually stabilized. So he was no longer experiencing such significant drops with transitioning from like sit to stand, complaints of less lightheadedness overall. So even though, I just wanted to stress, like even though he was performing most of the stuff seated, he was still working at a high intensity. So we were having him use the Borg RPE to rate the difficulty of the things we were doing with him, and he was still rating things as feeling very hard. So even though that might not seem like what we picture high intensity to look like for him, he was working himself at a high intensity, and we ended up seeing a lot of benefits from that. All right, so what I want to talk about next is specifically research on boxing programs for Parkinson's. So this is a study called High Satisfaction and Improved Quality of Life with Rocksteady Boxing and Parkinson's Disease, Results of a Large-Scale Survey. This is from 2021. This is the largest survey of Rocksteady boxing use in Parkinson's disease. So this survey showed that participants in Rocksteady boxing programs experienced improved quality of life, decreased depression and anxiety, decreased fatigue, improved social life, and decreased fear of falling. So they really reported a lot of improvements in those non-motor symptoms and quality of life. So I wanted to just touch upon the improved social life. That's an important aspect of Rocksteady boxing as well. So due to COVID, we obviously had to kind of put a pause on our group classes, but since then we've been able to resume smaller group classes with like appropriate spacing, and having people working in a little bit of a group setting, like it really does improve their overall like mental well-being, socialization. Like a lot of these people get to know each other, they become friendly with each other, and like that's a huge part of this. Like having Parkinson's disease can feel really isolating for some people, and being able to just like chat with your peers and relate to other people is really important. So that's a great part of the boxing program as well. Okay, so then I wanted to specifically talk about randomized control trials. We know that that's the best type of evidence that we have out there. So this study is called Community-Based Group Exercise for Persons with Parkinson's Disease, a randomized control trial. So this study compared a group boxing training to a traditional group exercise. So the boxing training included stretching and then specific boxing drills, resistance exercises, and aerobic training. The traditional group had stretching, resistance exercises, aerobic training, and balance activities. So we kind of see there's a lot of similarities between these groups. They're both doing stretching, they're both doing resistance, and they're both doing aerobic. The main thing that's different is that the boxing group is doing specific punching drills on punching bags, and then the traditional exercise group has more of a specific like balance component. So that's the main difference. The traditional exercise group demonstrated significantly greater gains in balance confidence than the boxing group. So that makes sense, right? They had a specific component where they focused on balance. So balance confidence improved. Only the boxing group demonstrated significant improvements in gait velocity and endurance. So 10-meter walk test and 6-minute walk test. Both groups overall did demonstrate improvements in most of the outcome measures. And those outcome measures were balance confidence, mobility, gait velocity, gait endurance, and quality of life. I was able to find one other RCT on boxing. So this one was called Boxing versus Sensory Exercise for Parkinson's Disease, a double-blinded randomized controlled trial. So this split people into two groups, a sensory group and a boxing group. So the boxing group was taught by a Rocksteady boxing certified coach. Each class was 3 times a week, 60-minute classes, and this was over a period of 10 weeks. The boxing class consisted of a warm-up, boxing specific exercises, so high intensity boxing drills, shadow boxing, jumping jacks, using the speed bag, and a cool down. The sensory group consisted of a warm-up and then sensory specific exercise. So what they mean by that is that they had the participants performing chair exercises where they were encouraged to complete the exercises slowly in a controlled manner and with their eyes closed. And this group had a warm-up and a cool down as well. So what this RCT found is that actually the sensory group maintained improved levels of disease severity compared to the boxing group. So the boxing group had initial improvements, but they did not have a lasting effect on the disease severity. And the reason for this, the lasting improvements to disease severity for the sensory group may have been due to the improved functioning of the remaining dopaminergic neurons as a result of the increased sensory stimulation that is passing through the basal ganglia during exercise. So something I wanted to point out here that I noticed in this study, the boxing group, they did not specify like how they were quantifying or how they were measuring if this was actually high intensity or not. So they weren't using heart rate monitors. They weren't using RPE. So something to consider is just maybe they were not necessarily working at a high enough intensity. Maybe they were working at more of a moderate intensity. So that was not specified. But something else I wanted to take away from this as well is that the sensory group had those long-lasting effects. So performing the exercises with eyes closed was very beneficial. So that's something we can incorporate into a boxing program. Like we can do certain circuits where patients are performing more sensory type exercises, things with eyes closed. Okay. Before we get into the summary, something else I wanted to just mention quick. There is a CPG, there's a clinical practice guideline that is coming out. Right now it still is a draft, it's still being reviewed, but it's a CPG for Parkinson's disease treatment. So I took a look at that, and what I wanted to just kind of mention is that aerobic exercise, so high intensity aerobic exercise, they have high evidence quality, and the recommendation strength is strong. So basically, if we're kind of going based off of that CPG, like we use CPGs to help guide our treatment. Like this is the gold standard. It's all evidence-based. So they're recommending that high intensity exercise, there's strong evidence for us to be doing that with our patients who have Parkinson's disease. So I thought that was important. And hopefully that CPG is coming out pretty soon. But just in summary, so we know exercise is beneficial for people with Parkinson's disease, specifically high intensity aerobic exercise. So maybe therapists who don't have much experience working with Parkinson's patients might be a little more hesitant to kind of push them into more of those high intensity ranges. But we really need to, like, I want you to take away from this, we really need to be pushing our patients and having them work in a more of a high intensity range. We can implement this in a variety of ways. So there's really no right or wrong way to do this. You should just find what interests your patient, whether it's boxing, whether it's dancing, but just kind of modify that and turn it into something that is high intensity, that they're working at, that it's hard for them. It shouldn't feel easy. It should feel difficult. And then just using a combination of methods to monitor high intensity. So we don't want to solely rely on heart rate. We want to kind of use a combination of these methods. They're all pretty easy to use, and we should definitely be implementing this as just part of our regular practice. Okay, any questions?
If you have any questions, feel free to either unmute yourself and ask or type into the chat. I do have one person did mention that Quakertown also
Has OT.
Has OT, speech and physical therapy.
Oh, I'm sorry. So Quakertown is a neurocenter. Yes. My apologies.
Yes, absolutely. What other questions do you guys have? I have one. You mentioned about combining sensory and boxing. Are you aware of any studies that are looking to combine that, or have you had any experience trying to combine those two?
So what we kind of end up doing, like with our Rocksteady classes, we actually are able to do some that are 90 minutes long now. So when we're doing the circuit training, we are doing some circuits that are kind of like specifically balance circuits. So we'll do like agility circuits, we'll do like the punching, we'll do like the footwork stuff, and then we'll also have some circuits where we're focusing specifically on balance. So that's where we can include like having the patient do things with eyes closed. So that part specifically might not necessarily be like as high, as high intensity as some of the other stuff, but within a 90-minute session, if we're taking like 10 minutes to be working on that, I feel like that's still beneficial.
What outcomes have you seen by incorporating thus far?
So like the outcome measures that we're using is pretty much all of the ones that were on that slide for the PD Edge. So if we're kind of looking specifically for improvements with balance, then we're using the mini best. And for pretty much for all of our patients that participate in Rocksteady boxing, like we're seeing improvements across all outcome measures. Sorry, what?
Oh, just if you noticed by incorporating some of that sensory aspect, have you just anecdotally noticed improvements in your patients?
I don't know if I can like specifically say it would be due to that. Like we are seeing like longer lasting improvements. Like patients will participate in the Rocksteady boxing program, and then we might transition them to maintenance therapy, where maybe they're just participating like once a week and they're doing other things on their own. And when we're kind of checking in and we're doing like our reevals and performing these outcome measures, like we are seeing lasting improvements. So I don't know if like it specifically has to do with like the addition of the sensory exercises or not, but overall, like with Rocksteady boxing in general, we are seeing long lasting improvements in these patients. And that's why a lot of them really enjoy it. They like to stick with it. Like it's something that they want to continue kind of lifelong.
Excellent.
Thanks.
What other questions do you guys have? Can you provide information on the MDS UPDRS, and do you use them
Yeah.
in your clinics?
Yeah. Like provide you want me to post something somewhere regarding it, or as far as using it in the clinics, like the most applicable use for us as like physical therapists or occupational therapists would basically, like, it's not something where we would do the whole thing because like I said, I think there's like 10 or so sections, but we would basically pull like the gait section and then the functional mobility section, and we could do those. So when I know Dr. Lasker is no longer with St. Luke's, but he was one of the primary neurologists for movement disorders, and he did the functional mobility and gait components of the MDS UPDRS in the clinic. So like when we would look at his notes, the score was already loaded in there from when he did it. So I know sometimes we would just kind of pull that and utilize that, or we could do it ourselves as well in the clinic.
Okay, thank you. All right, we have time for one more question. And then if you have any further questions after that, we'll please feel free to contact Dr. March.